The 5-point basic ophthalmologic examination. The basic ophthalmologic examination includes 5 steps: the visual acuity, the gross examination, the extraocular muscle examination, digital tonometry, and direct fundoscopy. In testing for distance visual acuity, we use the Snellen chart at a distance of 20 feet. The numerator corresponds to the distance at which the patient can read the letters on the Snellen chart, while the denominator corresponds to the distance at which a normal person can read what the patient can read on the chart. The normal visual acuity is 20/20. For example, if the patient can read the third line, TOZ, the visual acuity is recorded as 20/70. This means that what the patient sees at 20 feet is seen by a normal person at 70 feet. Test distance acuity one eye at a time. By convention, start with the right eye. Make sure that the patient completely covers one eye. If the patient is wearing correction, make sure that the lenses are removed first. Use an occluder or a cut palm to cover the eye to avoid unnecessary pressure to the eye. Start from the biggest letter, going down until the last line that the patient can read. If the patient makes a mistake, continue with the next line until he cannot read at least half of the letters of that line. Record the line that the patient can read without the corrective lenses. Repeat the steps again, this time using the corrective lenses, and record the line that the patient can read with the correction. If the patient does not have corrective lenses, proceed to testing using the pinhole. Record your finding as follows. For the right eye, the visual acuity is 20/100, improved to 20/50 with correction, and further improves to 20/30 with pinhole. For the left eye, the visual acuity is 20/100, improved to 20/50 with correction, but does not improve with pinhole. Remember, visual acuity must improve or stay the same as you do the testing from without correction to with correction to pinhole. If the vision worsens, just right, not improved. If the patient cannot read the biggest letter of the chart at 20 feet, ask the patient to come closer to the chart until he sees only the biggest letter of the chart, and record the distance. If the patient comes closer and is able to read the second line of the chart, ask him to step back until only the biggest letter of the chart can be seen. Remember, once the patient starts to move closer to the chart, only the numerator will change according to the distance of the patient to the chart. The denominator stays at 200. For example, at 15/200, what the patient can read at 15 feet, a normal person can see at 200 feet. Let the patient come closer to the chart until he is 3 feet away. If the patient still cannot see the biggest letter at 3 feet, do finger counting. Start finger counting at a distance of 3 feet, the closer at 2 feet, at 1 foot, until it is only 6 inches away. Record your findings as counting fingers at distance. If the patient still cannot count fingers at 6 inches, do hand movement. Move your fingers in such a way that no clues are made such as sound or air. Ask the patient if hand motions are perceived. If hand movement is perceived, determine light projection by shining the light from all 4 quadrants, and asking the patient to point where the light is coming from. Hand movement and light projection are reported as follows. Good light projection if 4 quadrants are correctly identified. Fair light projection if 2-3 quadrants are correctly identified. And poor light projection if only 1 quadrant is correctly identified. If the patient cannot detect light from any quadrant but can still perceive it, it is reported as light perception, or LP. If the patient cannot detect any light, double-check by placing your light directly on top of the closed lid. If no light is perceived, it is reported as no light perception, or NLP. Remember, always make sure that your reporting of your VA is accurate, as this will determine the prognosis of the patient. Patients who have hand movement with good light projection usually have favorable prognoses. Patients with fair light projection until NLP, on the other hand, usually do not have good prognoses. To review, start distance visual acuity testing with the Snellen chart at 20 feet until 3 feet. If the patient still cannot read the biggest letter at 3 feet, start finger counting at 3 feet until 6 inches. If the patient still cannot count fingers as 6 inches, do hand movement with light projection. If the patient cannot correctly identify as single quadrant, check for light perception. If there is none, a record visual acuity has no light perception. If the patient does not know how to read the letters, try using the number chart, the Landau-C chart, or the tumbling E chart. Near visual acuity is tested in patients over 35 years old, or patients who complain of blurring of vision at near. The patient is tested with both eyes open, and should wear their reading glasses if they are available. Hold the standard near vision chart at 14 inches, or 35 centimeters away. Record near vision depending on the letter size and the distance read by the patient. For example, if the patient can read the numbers 638 at a distance of 14 inches, record near visual acuity as J10 at 14 inches. There are special cases in which visual acuity cannot be recorded using the standard Snellen chart. For patients who are newborn to 3 months of age, shine a line on each eye and see if the patient will react to the light. Report this as positive or negative dazzle. Dazzle may be tested even in sleeping patients. For patients who are 3 months to 2 years of age, determine visual acuity by checking if the eyes are central, steady, and maintain fixation. Central, meaning there are no tropias. Steady, meaning there is no nystagmus. And maintained, meaning it fixates even when one eye is covered. Check if the eye fixes and follows a visual target. Make sure that your target does not make any other clues of its location, such as unnecessary sounds. Report your findings, if normal, as positive C, positive S, positive M, F and F. For toddlers and preschool children, you may check visual acuity by doing finger play at 20 feet or nearer if the patient is cooperative. Report this as FP at distance tested. You may also use the LEA symbols chart if the patient is able to follow instructions. It is tested at a distance of 10 feet and converted. The patient is given a card with symbols which he has to point to, depending on what is pointed to by the examiner. This is an example of the LEA chart. The gross examination includes inspection of the lids and the periorbital area. Note any abnormal findings such as hemorrhages, redness, and skin lesions. Palpate the orbital rim for fractures and step-down deformities. Check for hypoesthesia of the cheeks. Also check the conjunctiva for signs of infection, inflammation, or presence of foreign body. The semicircles on the chart represent the inverted eyelids or the conjunctiva. These are not the eyelids. Indicate if there is papillae, foreign body, or other findings. Place a slash if the findings are normal. Draw periorbital edema, hemorrhages, lacerations, and other gross findings here. Also indicate step deformities, crepitus, hypoesthesia if the patient had trauma. Check the lids and sclera for any abnormalities. Also check for proptosis and resistance to retropulsion. The normal position of the upper lid covers 1 to 2 millimeters of the upper limbus, while the lower lid rests on the limbus. Check for the Hirschberg reflex for eye deviations by shining the light. Orthophoric eyes will show the reflex at the center of the pupil, marked with an X. Esotropic eyes will show the reflex to be more temporal. Exotropic eyes will show the reflex to be more nasal. Hypotropic eyes will show the reflex to be more superior. Hypertropic eyes will show the reflex to be more inferior. Do not draw cross-eyed entries. The position of the reflex is enough to illustrate the deviation of the abnormal eye. Grade the deviation based on the position of the reflex. If the reflex is seen on the pupillary border, grade it as 15 degrees. If it is on the iris stroma, grade it as 30 degrees. If it is on the limbus, grade it as 45 degrees. If it is on the sclera, grade it as 60 degrees. Check the pupils for direct and consensual light reflex. When checking for the direct light reflex, shine the light on one eye and record the reaction of the pupils. The normal reaction will be a brisk constriction. Check also the other eye. When checking of the consensual light reflex, shine light on one eye. Check the reaction of the pupils of the other eye. The normal reaction will be brisk constriction of the other eye. Record your findings, and repeat on the other eye. Check also for relative afferent pupillary defect or RAPD. This is elicited by doing the swinging light test. Shine light on the normal eye. There should be normal direct and consensual light reflex because of the normal sensory input. Swing the light to the abnormal eye. The normal reaction should still be constriction. However, since there is less sensory input on the abnormal eye, there will be consensual dilation of both eyes. Here is an example of a patient with no RAPD. Notice that the pupils react briskly and remains constricted even if the light is transferred to either eye. Remember, RAPD is always relative to a normal eye. There is no bilateral RAPD. You cannot elicit RAPD from bilateral abnormal eyes. It is due to a decreased afferent or sensory input from the affected eye. It is still possible to check for RAPD if there is no pupil visible or if one eye has a non-reactive pupil. For example, if the patient has a total hyphema in one eye, you can still check for reverse RAPD. First, check if the eye with the pupil is normal. Swing the light to the eye with no pupil and check the reaction of the normal eye. If it remains constricted, then the eye without pupil has no RAPD. Record it as negative reverse RAPD of the normal eye. If the pupil of the normal eye dilates after swinging the light to the eye without pupil, there is RAPD of the eye without pupil since there is abnormal sensory input from that eye. It is reported as positive reverse RAPD of the normal eye. Report your gross examination findings as shown. Always note the pupillary reaction and the presence or absence of RAPD. Also note all pertinent positive or negative findings. In testing for the extraocular muscle movement, it is important to remember the 6 cardinal gazes and the muscles that act on them. Test DOM movement on these gazes by asking the patient to follow your finger in the directions shown. Arrowheads are used to report findings for the right eye, while circles are used to report findings for the left eye. Test both eyes or versions first. If versions are abnormal, test dot ions or one eye at a time. Grade the movement from 1 to 4, with 4 being full movement. Note for any nystagmus. Also ask for any pain on movement or diplopia on certain gazes. Normal DOM movement is full and equal for both eyes. The normal range of intraocular pressure is 10 to 21 mm mercury. Estimate IOP by using your index fingers to palpate the eyeball while the patient is looking down. Do not palpate with the eyes closed, as this will elicit the Bell's phenomenon, or the eye looking up when the lids are closed. The normal IOP is soft. Report your findings as soft if the consistency is estimated to be similar to the tip of your nose. Firm as it is as hard as your forehead, or hypotonic if it is as soft as your lower lip. In doing direct fundoscopy, it is important to first check if your ophthalmoscope is working properly. Check the light source. Use the largest diameter circle, and adjust the lens setting to 0. When examining the right eye of the patient, use your right hand in your right eye, and vice versa. You may adjust the lens power of the ophthalmoscope to correct for any errors of refraction of the examiner and the patient. A dimly lit room is the best place to do your examination, as this will dilate the patient's pupils. The patient must be comfortable and must be looking at a distant target throughout the examination. Start from about 1 foot away from the patient and locate the red-orange reflex. Slowly come closer to the patient at an angle of 15 degrees temporal to the patient's line of sight. Adjust the focusing wheel of the ophthalmoscope to bring the retina into focus. When a retinal vessel is seen, follow the vessel nasally until the optic disc is seen. Examine the optic disc, blood vessels, retinal background, and the macula. The findings are reported as positive or negative ROR, clear or hazy media, distinct or indistinct disc borders. The normal cup disc ratio is 0.3 to 0.4. The normal AV ratio is 2:3. Note for hemorrhages or exudates, and check if the foveal reflex is good or dull. The normal red-orange reflex is evenly colored and not interrupted by shadows. Check for any opacity in the lens and cornea that may dull the ROR. The normal optic disc is slightly oval vertically and pink in color, without hemorrhages. The cup is the central depression in the surface of the disc. The margins should be well defined, and the cup disc ratio should be less than 0.5, with no difference of more than 0.2 between both eyes. Check the retinal circulation and determine the AV ratio. The normal ratio is 2:3. Grade the ratio based on the second branching of the vessels and not as it comes out of the optic disc. The normal retinal background should be uniform red-orange in color. Check for hemorrhages, exudates, and other abnormal lesions. Check for any retinal attachments. Also check for the foveal reflex by asking the patient to look directly at the light. Here is an example of a normal-looking fundus. We hope that this short instructional video will make you feel more confident in doing the basic ophthalmologic examination and help you become better physicians in whatever field of medicine you choose. This instructional video was brought to you by your friends at the PGH Department of Ophthalmology and Visual Sciences.